So you are burning, you're creating a burn of the atria, and suddenly there is no conduction of electricity through that lesion, no conduction through that lesion, right? So you have the pulmonary vein here, and you make a burn here, and now there is no conduction. The electricity comes and stops there. So that's good, that's what you wanted. Your question was, now how do you know if these cells died or became dormant or are not functional?
In office follow-up.
Before discharging the patient and having to start again from scratch. So, and that is, to answer the question is, first of all, let me tell you the long story. The short story is we don't know. We don't have a good way to say for sure we're done. So there are two main ways right now that we are using. I say we as a community, I use only one of them. One way that we usually do is wait. As simple as it sounds, just waiting to see if this cell wakes up, becomes functional, it repairs the membrane and the channels recover. That is just wait. How long? We don't know. I wait at least 30 to 45 minutes for simple ablations. I usually wait about 60 minutes or more for AFib, because the success rate, for example, for AVNRTs or atrial flutter ablation is very good, and usually you don't see reconnection of things after 30 or 45 minutes. With the pulmonary veins, I personally, and this I emphasize it personally because I have no data behind it, I wait 60 minutes because I can do other things for the patient in the meantime. I could do a full EP study. I can do an ablation of the flutter or look for AVNRT. I look for other things to do while I wait. And so I just wait. It's only 15, 30 minutes more than I normally wait for any burn. And you'll be surprised about how many times you find that the conduction recovered. And if I wouldn't have waited for 60 minutes and the conduction recovered, the patient comes back. It could come back with AFib. I don't know if it will come back, but it could. So since the patient went through the trouble of setting, taking the day off from work and going through the risk of all the procedure, 15 minutes more, it doesn't change the risk of the procedure, but it might save an extra one. So do I have any scientific data to say that this is the right thing? No. And I don't think I'll have it or anybody will have it. So this is just what I do. Other groups use adenosine. Adenosine, anybody knows what adenosine does?
Concussion.